All right. Hey everyone, welcome back to another virtual shadowing session at Hearts for Health today. We're excited to start off this week with a session on oncology. We're joined by Dr. Rana. She's a oncologist in Toronto, Canada. So I think this is the first time we're going to be talking about oncology from our sessions. This is a new specialty and we're excited to see it today. A few reminders for those who are listening in, especially if you're new. This is going to be some new information for you. Towards the end of each of these sessions, we have a Q&A. So this Q&A is a chance for you to allow the speaker to respond to any of your questions. If you have any questions, type them in the chat and we'll get around to them at the end of the hour. And if you want to stay updated with future shadowing sessions, you can do that through one of two ways. We have our Instagram, which is likely how many of you heard about us, where we post our flyers for each speaker and also a few other announcements for other programs outside of shadowing. We also have our listserv. So our listserv is an email that we send out weekly on usually Tuesdays and sometimes Mondays with announcements for future shadowing sessions. That also includes flyers. It also includes announcements. So more or less, you'll get roughly the same information through either, just up to you over whichever you prefer, either following us on Instagram or joining our listserv. Both are great ways to stay tuned. If you would like to join our listserv, to do so, you can email us at shadowing.h, the number 4h at gmail.com. We can manually add you on through just receiving your name and email address, your preferred email address. We recommend that's a personal Gmail or Yahoo account if you do so. Also, we have a subscription form at the bottom of our pages on the website. So either one of those ways works to get onto our listserv. If you have any questions, as always, feel free to contact us. But with that said, I don't want to take up too much time. So Dr. Rana, feel free to take it away.
Excellent. Thank you, Michael. So yes, I am happy to be here and share my experience, and hopefully you may get something out of this. And I'm happy to answer questions, I guess at the end, unless there's a way to ask them as we go along, then I'm happy to do that as well. So my name is Dr. Poonam Rana. I am a medical oncologist. I work in Toronto, as Michael said. So I'll talk a bit about that. Oops, sorry. Okay, so I just started off with talking about the journey to medicine and a little bit about the why. So everybody has their own why. And I think it's really important to take some time to really reflect on why it is that you're wanting to pursue a career in medicine. Because sometimes we do kind of get caught up and may not really have the time to think about what elements of it are that really inspire us. And then those can then help us sort of navigate which direction within medicine we want to do, or if it's something that we want to do in the first place. So for myself, you'll see here a photo of a girl holding her father's hand. So my father is a family physician. And so I grew up with that exposure in my house. It was in Toronto as well. It was a time when a lot of family doctors did house calls. So I did get to go sometimes to see patients with him in their homes. And I really liked seeing the impact he was able to make in his patients' lives and the families' lives. So that's the photograph right there with the hand holding. Medical oncology is certainly a specialty which incorporates a lot of hand holding. As you can probably imagine, we're dealing with cancer and some really, heavy duty diseases. So that was actually for me something that I really did want to also incorporate into my own career one day. Seeing my dad, he did a lot of palliative care, which is like end of life care. And so there was that component as well. There's a picture of Terry Fox. I still remember feeling very inspired as a young girl when we used to do Terry Fox runs. And I don't know if people here are familiar with Terry Fox or if he's more of a Canadian icon, but basically he was quite young, like an adolescent who developed sarcoma. He did lose his leg, but he did a run across Canada. Unfortunately, didn't make it the whole way. He did progress his disease and he died, but he really raised a lot of awareness in terms of cancer, raising money and research. And then finally, there is a photo here of like basically a molecule or some sort of molecular biology thing. So for me, I really did actually enjoy biology, which was good because there's a lot of studying biology when you are in medicine. So those were my whys. Now, what I wanted to just touch on next is what was my personal journey to medicine? What were the things that I did? And so a little bit about my background. So I did a Bachelor of Health Science degree at McMaster University. So that's one of the bigger universities here, about an hour and a half from Toronto. And I did do a bunch of research experiences in my undergrad. So I worked in a biology lab. By the way, in terms of doing research in a biology lab, just not having any background in that, I literally emailed like 40 different like professors and didn't hear back from anyone but maybe two. And then I kind of just tried to get in where I could. And so that just only to say that sometimes it's not easy to get these types of experiences that you may not know have any connections. I also volunteered in hospitals as a actual volunteer in clinical experiences, as well as doing some organizational positions. And I also did some research as a volunteer for the hospital and was able to get a poster presentation, and that was a really great experience. In terms of committees, I was involved as my first year. I just joined a bunch of committees to see what they were like. But then when I was in my undergrad, in my second year and my third year, I became more involved on a committee level with Health and Science Society, where I was the second year representative. And then I was actually very passionate about Amnesty International. And in my second year, they asked me to be president because the then president wanted to step down. And so that was really an amazing experience in not only being involved with a charity that I was very passionate about, but also just getting that leadership experience. And then extracurricular was also very important to me. I was involved with a dance group, and we were actually competing quite a bit. So I did have a lot of time doing that. And I also loved to travel and made sure that I was able to incorporate that. So this is, I think, part of the application to go into medical school is just being cognizant of your resume, right? Like you want to try to show that you have made an effort to learn about the field of medicine, that you've made an effort to really get different varying experiences in that, to show that you are somebody who is willing to take initiative and take leadership roles. And then also someone that has some non-medical things that you do as a balanced person, because it's really important to have a balance, because once you're in medical school and then residency, it's really quite tough. And it's important to have some sort of outlets that you can keep in your life to keep you feeling not overwhelmed. So now a little bit more specifically about the journey to medical oncology specifically. So how to go into medical oncology, a little bit more technical in terms of the procedure. So I did do my undergrad, like I mentioned, and then after that, I went to medical school at McMaster University, which is in Hamilton, the same university that I did my undergrad in. And that was a 3-year medical school. Most are usually 4 years. There's 2 in Canada that are 3 years, so they're a bit condensed. Following that, I did a residency in internal medicine, which is a requirement in order to go on to become a medical oncologist. So it would be 3 years of internal medicine, which I did at the University of Ottawa. And then following that, you would reapply then at that point to go into a subspecialty of internal medicine. So internal medicine includes basically all of the sort of internal organs and the specialists for that. So that would include a cardiologist for the heart, respirologist, hematologist, gastroenterologist, immunologist, medical oncologist, probably missing some. And so, yes, and then you kind of reapply again and try to get into the subspecialty that you want, and then do an additional 2 years in that. At that point, after you complete a residency in medical oncology, you have an option of saying that you want to work in the community. So you can go and start working. You're qualified as long as you pass your board exams. Or you can say that you want to do additional training and want to be a little bit more subspecialized and also have more of an academic position. So me, I actually was thinking at the time that I wanted to be more academic. So I did pursue a breast cancer fellowship, which was 2 additional years. And I did a master's of epidemiology, so an MSc. Interestingly, I wasn't really sure. And so I just did this because I thought maybe I wanted to do academics, but in the end, I ended up being in the community because that ended up being a better fit for me. But that's sort of the path in which to do that. So what is medical oncology? Oncology, as you may know, or as you may have picked up, is cancer, right? So there's different types of oncologists. So there's different types of doctors that would treat a patient that has a diagnosis of cancer. So there would be the surgical oncologist who would be doing the surgeries to remove the tumor. Then you have the medical oncologist, which is the doctor who treats what we call systemically. So that includes chemotherapy, oral pills, really any drugs. And then there's also a radiation oncologist, and that's also a cancer doctor, but they treat the tumor from a radiation perspective. And so they do a very different training program. In fact, they don't go into internal medicine right from medical school. They go straight into radiation oncology. So a medical oncologist is a branch of internal medicine. Like I mentioned, we do systemic treatment of malignancy. And then we work closely with all the other cancer doctors to come up with the perfect plan for each patient and how to manage their cancer. This is a little bit of a timeline about cancer and the history of it. So you can see like 3000 BC, there's counts of tumors growing on different parts of people's bodies, and basically surgical treatment was the only known treatment option. So that's really what was happening right up until 1900s, really early 1900s, when Marie and Pierre Curie started to treat tumors by using X-rays. And so then the radiotherapy and radiation oncology was sort of given birth as a field of medicine. And it wasn't until World War II when there was some mustard gases that were being used in war, and they realized that these soldiers or Marines or whoever was being exposed, they were getting their Hodgkin's lymphoma cured, and that really kickstarted the investigation into medical oncology, i.e., treating tumors from a medical perspective. And then you can see here in around 1980, there was some more treatments coming out that were more targeted. And around 2010 is when immunotherapy started coming into the picture, which we'll talk about a little bit more. And so really, traditionally, it was chemotherapy when medical oncology was born, and like it's as a subspecialty and being recognized as its own subspecialty is actually fairly new. It was around the 1980s, I believe, that it was recognized as its own branch of internal medicine. So initially it was just chemotherapy. That was it. And now in the last 20 years, we've had a lot more treatments emerge. So there's really this is a very fast, rapidly growing field in terms of research and new medications. And so this is another, just reiterating the same thing, which is that the timeline in terms of cancer treatment, you could see here. We won't go into too much detail here. If anyone has any questions later, we can certainly talk about more details about any of the treatments. Here is a slide on immunotherapy. So immunotherapy is very exciting because it's showing us results in cancer that we've never seen before. So I graduated from my residency program in 2012, and we were not using immunotherapy as a standard. It was just emerging. And so even in my own career, I have seen just such rapid changes in the results we can offer patients, mostly because of immunotherapy. And there's also some other more targeted medications that have also done the same thing. So what immunotherapy does is it actually, so a tumor can sometimes figure out a way to put a stop or put a break on your immune system. And so normally our immune system is able to find these abnormal cells and just kill them. And therefore they prevent an abnormal cell from becoming a tumor. So sometimes these abnormal cells, they can figure out a way to block the immune system, and therefore the immune system is not able to kill them. So immunotherapy, the approach with immunotherapy is it's actually taking the brakes off so that the tumor has these brakes, but the immunotherapy treatment can remove these brakes and therefore allow the immune system to target and kill the cancer cells. And I really do love that, because it just shows that our bodies are really doing a lot of the work. And when we really enhance the sort of natural human ability to heal, we can see such amazing results. Another exciting area in oncology is NGS, which is next generation sequencing. So for anybody who's interested in really the molecular advances in terms of genetics and mapping out genomes and finding abnormalities and then trying to target those with treatment, this can be a very exciting area. So basically with the understanding about how to sequence genomes in terms of patients and in terms of cancers as well, there's been so many advances in terms of finding treatments that can target these abnormalities. So I wanted to talk a bit about what a day as a medical oncologist would be like, albeit every day is not the same. So I just really wanted to touch on what is it like to be a medical oncologist. And so as typically this is one field in medicine where we really do a lot of outpatient clinical work. So most of our patients we're seeing in as an outpatient, and we can't really just like open up a shop somewhere like a private practice and start just treating cancer patients. As a medical oncologist, we really need to work with a team. Right. So we're administering chemotherapy. So not only do we need to have nurses, but we need to have trained nurses who are trained in chemotherapy. We need to have pharmacists. We need to have drug access coordinators and social workers and dietitians. And so as a medical oncologist, it truly is one of the fields where you couldn't do it alone. You really rely heavily on your team to support you and to support your patient, and you kind of work together mostly in an outpatient setting. You would typically do some inpatient work as well, because of course you can imagine that these patients that we're treating may get sick, may get complications, may progress, and would have to be admitted to hospital. And so certainly there would be some inpatient work where either the doctors who are admitting the patients may ask for a medical oncology consultation, or in some hospitals, the medical oncologist would be the one to actually do the admission themselves. In terms of on-call, there's really on-call is an aspect of all areas of internal medicine. But medical oncology, there's not a lot of medical oncology emergencies, and there's a few such as like cord compression, hypercalcemia, febrile neutropenia. So we have a few, but usually these would come under the umbrella of general internal medicine. And so like, depending on the hospital you may work at, the call situation and the call, the way that it's set up may be different in terms of would the medical oncologists have to come in and see these patients, or do other doctors admit the patient. So usually what I'm trying to get at is usually as a medical oncologist, on-call is not that bad. Most hospitals that I'm aware of have set up where the medical oncologist is rarely called in sort of overnight or anything like that. Another big aspect of tumor board meetings of medical oncology is tumor board meetings. And so what that is like I mentioned earlier, that there's multiple kinds of oncologists, a surgical oncologist, there's a radiation oncologist. And so these cancer patients can have tumors that are quite complex and would require different elements from the different kinds of oncologists. And so this is one area where we often discuss patients that need to have all the different kind of doctors sitting in the same room, discussing the case and coming up with a plan altogether. And so attending regular tumor board meetings where we discuss all these such patients is definitely a big aspect of being a medical oncologist. And it would be an aspect of being any oncologist. So a radiation oncologist or a surgical oncologist they're the ones that attend the meetings with us as well, along with radiologists, because a lot of what we do in medical oncology is we do images to see what's happening in the body. And so we would need some input in terms of reading the images from CT scans and MRIs. And finally, as a medical oncologist, there is a lot of opportunity for research involvement. So I mentioned earlier that there is sort of an academic type of a stream or a community hospital stream that you could choose as a medical oncologist. But the way that cancer treatment and like just all the research is expanding is that there's many different clinical trials that are opening up all over probably each province or state, but also all over Canada and the United States. So being in Canada, we get multiple patients that, for example, may do genetic testing and find out that they have a genetic mutation, but really we don't have that much information about it. But there may be the Mayo Clinic in the US, which has a clinical trial which targets this exact mutation. And so patients may want to go there and see if they're eligible for that new treatment. And so really being open to what research opportunities are there for your patients is an aspect of every medical oncologist care, whether they're working in the academic center where there's a lot more clinical trials being conducted, or if they're in a community hospital, which may have some clinical trials, but more so we just still have to be aware of what clinical trials may be there and then sort of send patients that way. So I was going to move on to do some cases, and I'm hoping that this may give you a sense of the type of patients we see and the sort of typical scenarios and what we do as medical oncologists. So this first case is a 60-year-old female who presents with a red breast, has a large bump on it. And she went to her family doctor who ordered a mammogram along with an ultrasound and a biopsy, which showed that it's an invasive ductal carcinoma. So that's the most common and garden variety type of breast cancer. And it measures about 6 centimeters, and there's some inflammatory changes in the skin. And then there is some more information which says ER positive, PR positive, HER2 negative. And this just talks a little bit about the specifics of the tumor and the fact that the ER is estrogen receptor, it's present, the progesterone receptor PR is present, the HER2 receptor is negative. And we use this information then to really target the treatment that we're going to give this particular patient with this tumor. So because it looks like an inflammatory breast cancer, the patient, so automatically the patient is referred to a surgeon, but then if it's a small tumor, typically they'll take it out. But when it's a bigger tumor, they will typically refer the patient to a medical oncologist, such as myself, for consideration of getting some neoadjuvant chemotherapy. So neoadjuvant means that it is being done prior to the surgery. The medical oncologist recommends neoadjuvant chemotherapy because it's known to shrink the tumor, to make surgery easier. It also allows us to monitor whether the chemotherapy is working or not. And it gives us information about the patient's prognosis at the time of surgery. So prognosis really means what the expected outcome would be for the patient. So basically, when we do neoadjuvant or pre-surgical chemotherapy, we can see based on what is left over at the time of surgery, what the patient chances are for the cancer to return. And then based on that information, we can either recommend more treatment, or we can say that they don't need more treatment because the prognosis is quite good. So it can be very beneficial to do neoadjuvant or pre-surgical chemotherapy. So this patient completes 4 cycles of AC, which is a chemotherapy, which consists of 2 chemos called doxorubicin, cyclophosphamide. And then after that, she has 4 cycles of paclitaxel, which is a different type of a chemotherapy. So she has 8 cycles of chemotherapy. She then goes on to surgery, and she's found to have only 0.5 centimeters of cancer remaining. So previously it was much larger, and so it's much smaller now. The patient is referred to a radiation oncologist for adjuvant radiation. Patient is offered 5 weeks of daily radiation to the breast. And in terms of how, as a medical oncologist, what we recommend to further reduce her risks of breast cancer recurrence or coming back is to go on an anti-estrogen treatment for 5 years, which is an oral pill to take once a day for 5 years. And that really is a standard treatment that we do for patients who have estrogen positive breast cancer, like she did because it was ER positive. So once she completes the 5 years, then she can discontinue that. But from the point of her diagnosis onwards, she would need to have an annual mammogram. So that would be every year rather than the recommended every other year for women that have not had breast cancer. And she would be recommended to have breast examination done, and there is a recommended schedule for that. So it's every 4 to 6 months for the first 2 years, then every 6 to 12 months for years 3, 4, and 5, and then annually for years 5 and after. All right, so that's the first case. The second case is a 7-year-old Caucasian male, past medical history, hypertension, high blood pressure, and gout. The patient's medications are hydrochlorothiazide, ramipril, and allopurinol. The patient has a 15 to 20 pack year history of smoking, is a retired mechanic, and married with no children. So the history of presenting illness, basically that means what brought the patient to their current present illness. So the patient went to family physician or general practitioner for routine checkup and was noted to have a wheeze on exam on the right side. So the family doctor sent the patient for a chest x-ray and found an abnormality in the right lung. The patient was otherwise asymptomatic, so felt fine, but just had a wheeze on exam, on a routine exam. So because of that abnormality on the chest x-ray, the patient was sent for a CT scan and was found to have a 3.6 centimeter right upper lobe spiculated mass and a 16 millimeter right hilum lymph node, a right paratracheal lymph node, and a right subcarinal lymph node. So those where it says right hilum, right paratracheal, and right subcarinal, those refer to lymph nodes. The patient went on to have a biopsy of the right upper lobe spiculated mass, and it turned out to be an adenocarcinoma, TTF1 positive and napsin A plus. These are things that the pathologist would look for and report And based on these types of findings, that's how they confirm whether the tumor originated from the lung or could it have been a metastases from another place, such as the breast, or really lots of different cancers can metastasize to the lung. And they then go on, the pathologist, and they note that the cancer is EGFR negative, ALK negative, and PD-L1 1 to 49%. So again, these are aspects of the pathologic findings that help us as medical oncologists learn more about this particular tumor. And based on these findings, we can then specialize our treatment that we offer and try to target possible abnormalities or mutations. For example, with EGFR, the patient was negative, but about 10 to 15% of lung cancer patients are positive, and then they can have a very specific targeted treatment that would target that mutation. So these are the patient's actual images, and you can see in the top, there is that's the right upper lobe spiculated mass. And in the lower three slides, you may be able to notice some large sort of masses or bumps, and those are those enlarged lymph nodes that were being mentioned. The patient then goes on to have further staging. So this is a confirmed lung cancer, but we want to know, has it spread anywhere else? And that's always one aspect of the initial stages of finding a breast of any cancer. So the bone scan is negative, so it has not spread to the bones. The CT of the head is negative, and the MRI should be written there is also negative. PET scan shows that there's a subcarinal mass, and a mediastinoscopy is where they take a scope and they go into the mediastinum and they visually look inside to see the different lymph nodes, and they sample them. And then they will be, by sampling the lymph nodes, they can have a better idea of what is the actual stage of this cancer. So there's no need to go into like the actual what's 4R and what's 2R, but basically the lymph nodes have numbers in the mediastinum, and that's how we're able to identify which ones they are referring to. So these two right-sided lymph nodes are positive. And these are images of the PET scan. So you can see the right upper lobe mass, and then you can see that there are some lymph nodes that are lighting up as well. So this patient was reviewed at MCC, which is the Multidisciplinary Cancer Conference. And it was recommended that the patient have definitive chemo and radiation. So the patient does not have cancer that is spread anywhere else. And so this is a curative approach to treat the patient with concurrent, that means at the same time, chemo radiation. And that would be with one of the standards. There's different types of chemo standards that can be used. This particular case, it was cisplatin and etoposide. And this patient completed their care in November 2015 in terms of their standard treatment at the time, which was concurrent chemoradiation. So at the time, 2015, this was the standard treatment. Now, this patient was in Toronto. There was a clinical trial which was called Pacific, and in this clinical trial, they were taking these types of patients, and they were seeing if they would benefit from an additional treatment. In this case, that was called durvalumab, and you can see here it says randomized to durvalumab versus placebo, 2-to-1 ratio. And so durvalumab is a type of an immunotherapy. And so in this specific clinical trial, they would take patients who completed chemoradiation and then randomize them to two different groups. Either they received durvalumab immunotherapy for 1 year, or they received placebo for 1 year. So this patient went on to this study, tolerated the treatment really well, and now continues to be on surveillance. And so that's, it's always exciting when you have patients that are on clinical trials, which then subsequently get published and you realize that the patients were on a drug that really statistically significantly was shown to prolong overall survival. And so that was the case with this patient. And now, for example, durvalumab is now the standard treatment that we would give patients like this who present. If the same patient presented now, they would just be getting chemoradiation like they did, but they would also be getting durvalumab as a standard now, which previously was only done because of a clinical trial. A third case is a different kind of a scenario that we get. So this is a 93-year-old male who's admitted to hospital with falls and anemia, hemoglobin of 61. And generally speaking, a patient who is elderly, who presents with anemia, you always have to rule out colon cancer. And this patient, sure enough, is found to have a new locally advanced sigmoid tumor. So the patient undergoes staging scans to see what is the extent of the tumor, and it reveals that the patient's cancer has already traveled to the lung and the liver. Because it is metastasized, he's not a surgical candidate. So that surgical treatment of his cancer is not an option for him. So the options that remain would be to have systemic chemotherapy, and really radiation treatment is also not really a candidate, an option for these patients as well. So really the only option for these patients would be to do some chemotherapy. And that would be not to cure the cancer, but it would be to try to shrink it, and by doing that, to increase the overall survival. So a patient who presents with stage 4 colon cancer, who does not do any treatment at all, they have a life expectancy of 3 to 6 months. And a patient who does go through all the standard chemotherapies, they're expected to live for 3 to 4 years on average. So some people longer than that, and some people less than that. So it is quite a bit of an improvement in overall survival. However, many patients don't really like the idea of going on chemotherapy for the rest of their lives. Many elderly patients may feel more comfortable with saying that they've lived their life and they'd rather not go on treatment, and they'd rather just focus on staying comfortable for the remainder of their life. Now, with this particular patient, now it's not to say that we don't offer treatment to patients just based on their age, because of course, age can be very different in very different people. Some 63-year-olds are in worse condition than some 93-year-olds. But in order to offer chemotherapy, there must be really some basic level of functioning. Otherwise, it's not deemed to be safe to administer chemotherapy, because there are many side effects to it, potentially. And so one thing is that an inpatient in most places, they really need to be able to go home, be living at home independently, to prove that they're strong enough to actually proceed with the chemotherapy and to kind of get through it. So this patient discusses his option with the family, i.e. chemotherapy versus no chemotherapy, and he makes a decision that he does not want to have chemotherapy. And at this point, the palliative care team is introduced to the patient, and a referral is made to transfer him to hospice for his end of life care. So the palliative care team is really the sort of end of life team that gets called in when there may be a patient who's towards end of life, or they're also very excellent at managing pain and symptoms. So sometimes they get involved with patients much earlier on if there's some complications in that patient's pain or other symptoms, and managing those. So that's that third case. So different from the others, but very much a case that we see very often. So so just finally, I just wanted to leave off with some advice for pre-meds. So I would say that everyone knows that getting into medical school is so competitive. That's just the basic reality. And I went to medical school in 2004. So I think that things have just gotten harder and harder in terms of how competitive things are. But I would say that probably a lot of the same principles still apply. So, as much as possible, take classes that interest you in undergrad. So, for me, I took some courses that were really, I was recommended not to take them because they were not quote unquote bird courses. I don't know if that term is still used, but a bird course was considered one that you could kind of do minimal work and try to get a good mark. And then by that, doing that really boost your GPA. But I think that I look back at my undergrad and I think about my Shakespeare class that I took, or I took one that was called World's Religions. And really, I was very passionate about the topics. And yes, they did take a lot of time, and they were not easy by any means. And I had to work for those marks harder than in some other courses, but they really were very meaningful to me. And I think that really motivated me to kind of do better in them. And so I think looking back, I always sort of remember some of the things I learned in those courses. And I think that it's helped shape me as a more well-rounded person. And so I would say, as much as possible, take the classes that interest you. Now, that being said, of course, GPA does matter. And so perhaps, going into some sort of really advanced physics courses may not be the best option in terms of, boosting your GPA, but that is just generally, I would say that try to take classes that interest you so you can really enjoy them and the experience. I would say have an outlet for having fun and for some creative self-expression. It's so important because we sometimes get so focused on the end goal, which is to get to medical school, that we forget to have fun along the way. And there's no reason that you can't get there without also having fun. And so I think that's really important in maintaining sanity, which is to having a good outlet, having fun. I would say question why you want medicine, because sometimes we do introspective work and we may surprise ourselves as to why we want something and may realize that it is or it isn't what we wanted at all. So I would say really question why you want it, make sure you want it. It's certainly not an easy road to take in terms of getting there and into medical school. And then once you're in there, it's certainly not easy to get through medical school. And then certainly residency is quite challenging. And then before you know it, a decade of your life has gone by. So you just want to make sure. And so you wouldn't want to go through all of that and realize this is not really what I wanted. I'm not actually happy doing this, right? So just make sure that you want it for the right reasons and that you actually really do want it. And be curious about the different areas of medicine and try to learn about different areas as much as possible, but also keep an open mind once you go through the process. So that is what I have, and I would be very happy to answer any questions.
All right. Well, first of all, thank you so much, Dr. Rana. What a presentation, especially for the first time seeing this specialty. I'm sure this was a very, very engaging and exciting experience for a lot of people who are joining us today. So thank you so much. We're going to start off with our first question, just in the order that we received them. And to those who are listening in, if you have more questions, feel free to type them in. We might be able to get to them with the time that we have. So the first question being, how did you go about choosing your specialty so early on in medical school?
Yeah, so that's a good question. I think that some subspecialties you do need to choose pretty early on, to be honest, like some of the very competitive specialties, ophthalmology, dermatology, because there's some subspecialties that you really need to get into right away. Like oncology is one where first you do internal medicine. So you kind of gain some time to really reflect on what you want to do. Is it oncology? Is it just general internal medicine? Is it cardiology? You have a bit more time, but if you are wanting to be in one of the more competitive subspecialties, then yes, you do need to usually you do need to figure that out sooner than later because of the fact that it is so competitive. And so everybody's doing rotations and research and networking within that field. So, some people come in and they're saying, this is the subspecialty I want. For me, it was not that easy. So you're saying, how did I know so early on? I did not actually know in medical school that I wanted to be an oncologist for sure, but I was very interested in many of the areas of internal medicine. And I could see myself working in many of those different areas. And so even though I gravitated towards medical oncology, I kind of left that open. So yeah, I think that it's a tough balance. It's one where you have to, if something is that you're very passionate about, you got to go for it. But at the same time, you got to keep your eyes and ears open to see if there's something you may like better. So I hope that helps. It's a very good question, and it's not an easy one to answer.
Absolutely. Our next question is just generally being a physician, not necessarily specifically an oncologist. What do you believe is the most difficult part of the job?
A very good question. I think that we're dealing with some really serious heavy duty issues that affect people's lives so immensely, so there's a pressure to make sure that we're always on top of the research, the data, are we doing the right thing for this patient? Because especially as medical oncologists, like it can be a matter of life and death. And so I think there is a lot of pressure that way, that when we're at work, everything has to be very serious. And sometimes there's no straight answers to what we should be doing. For example, there may be one case, and if you were to poll 5 different oncologists, they may give 5 different recommendations. So it's not to say that any is right or wrong. So sometimes having to make choices for patients when there is that uncertainty, and just having that pressure of knowing the implications of your choice and recommendation could be so impactful to them. That's probably for me one of the hardest things as being a physician, and it certainly is relevant to so many areas. Family practice is a big one too, right? Because you just have to be able to decipher what something, like, for example, we see cancer patients, and sometimes they were seen by their family doctor for a while and it was not detected, but it's not at the fault of the family physician, right? It's just sometimes these things are hard to detect. So it can be hard if a doctor knows that they may have missed something, or may have done something that may have retrospectively not been the choice that was the best for the patient. So that's probably it.
You mentioned oncology being a life or death sort of practice. On that same line of thought, a question that we have here is, how do you deal with the emotion that comes with bad news in oncology?
Very good question. These are all very good questions. So yeah, we were definitely breaking bad news a lot, but we're also giving good news a lot, right? And so I think that, it's a very delicate balance between being in the moment with your patient and really allowing yourself to feel, happy when there's a good outcome for them, or sad when things are not going the way that they hoped that they were. But then kind of having to let that go when your next patient comes in. And so I think what we learn to do is be very mindful in the moment. And so when we're in the moment with the patient, we're there with them, we're present. I do openly say that I think it's okay to share tears of happiness or tears of sadness with your patient. But what does happen, and what we have to do, or we wouldn't survive, is that, we then have to just be mindful and say, okay, well, that's now gone. That patient is not in my room anymore. I have to, be present in the moment and be there for the next patient, right? And so, of course, it's not perfect. And sometimes we may bring some things home that may be particularly, that may have affected us, but yeah, it's a skill that, the good thing about any area of medicine is that there's so much training. And so even with medical oncology, by the time you're done your training, you have pretty good experience, and you've learned from your mentors, and you've learned from your own experiences really how to handle these situations.
Our next question is from a student who asks, do you begin treating the cancer like it will not metastasize and then change the course of treatment if it begins to metastasize? Is that the way that you approach each case?
So that's a good question. So really every case is unique. So there are some chemotherapies that may be used in both curative settings and metastatic settings. So it may not be necessarily true that you would have to change the treatment for a curative versus a metastatic setting. But yeah, there may be cases where you would have to. Now, if a patient is on a treatment and while they're on the treatment, the cancer is growing and it becomes metastasized, then that, of course, would mean that the treatment's not working, right? So that would mean that you have to change treatment because whatever they're on is not working. But yeah, there are some, we sometimes treat different cancers or different scenarios with similar treatments. I don't know if that answers your question.
Yeah. We actually have another similar question, but more so about comorbidities. So with patients who have diabetes or autoimmune diseases, how does treatment change for them? What are the considerations you make?
Very good. A question again. So every treatment option has its own risks risks inherent to that treatment, right? So we certainly have to look at patients' comorbidities. Sometimes they may preclude certain treatments, and so we cannot give certain treatments if a patient, we may not be able to give certain chemotherapies if a patient has diabetes, particularly if they have end organ damage, like with neuropathy, or if a patient has an autoimmune disorder and they're on treatment for it actively, then they likely cannot have immunotherapy. So there certainly are certain cases where we are not able to give certain treatments to certain patients. But for the most part, we're able to amend our treatment or support them in ways, or dose reductions. So that's when we can kind of reduce the dose of their treatment to accommodate for their comorbidities.
During your training, or maybe during undergrad, during even high school, if you were considering it then, did you ever think of training or practicing in the US instead of Canada? Was that ever a thought that crossed your mind?
Not for me personally, just because I grew up in Toronto and my family's here, and I'm really happy with our healthcare system. So it's just very I'm just very comfortable in our healthcare system, and I don't know that much about the American healthcare system, to be honest. I think that I wouldn't be against working in the States. I think that there's a lot of similarities between the way we practice in Canada and the US. And so yeah, but personally, no, it hasn't been something that I wanted to do.
You happen to know if someone was to make that transition, would they have to take their residency education in the same country? If they're to move from the US to Canada or vice versa, would they have to have residency there?
So as far as I understand, you don't have to redo your whole residency. There's different ways to do it. For example, my husband, when he was 18, because he's also from Toronto, he, at the age of 18 from high school, he went straight to Ireland to go to medical school. And it's like a 6-year medical school that you go straight from high school. And then he came back and he actually did his residency in Canada. And then he works here because his residency's here, even though his medical school was there. On the other hand, I have another I know somebody else who went to the UK and did the same medical school program, that like the 6 years right after high school, but they did the residency there. They worked for about 2 years, and then they were able to come back to Canada, and they're practicing now. So I know that there is ways, but I don't know the details.
No worries. I also wanted to ask, we hear sometimes from Canadian applicants that they just have a difficult time finding shadowing and clinical experience opportunities. Did you find that to be the case? Is that something that in your personal like anecdote of having gone through this whole process that you find difficult?
So when I was training, there was no, I was not aware of anything that's like this, like a virtual shadowing. I don't think that really existed very much. But in terms of shadowing with, I think that once you're actually in medical school, it's usually not that difficult, because usually your program will be able to help you. So if you go up to them and say, I really want to work with a dermatologist, then usually they can recommend preceptors who are connected with that medical school and who would be willing to take you on. So that's actually how I got connected with who ended up being my mentor for my fellowship. So I came back and I did a breast cancer fellowship with him. But when I was in medical school, I just got randomly paired with him because I wanted to do medical oncology rotation and shadowing. And then I really liked working with him. And so I kind of came back to him and he became my mentor. And so yeah, so that's not really been my experience, but I don't know if things have changed. Yeah.
We have two more questions, I think, that we'll go through before we wrap the end of the hour. The first one is, let's say in the scenario where a patient's family doesn't want the provider to inform a patient of some bad news, because we know that physical and mental health are intertwined, they're connected together. Is it appropriate for the provider to just not disclose that to the patient if that family wishes for that to be the case? So what are the legalities there? Do you know?
Yeah. That's not uncommon, right? I work in a hospital with, it's funny, like, my family comes from an Indian background, and there's a lot of immigrants, and in a lot of cultures, you kind of don't tell people when they're sick because you worry they'll give up, and so I definitely do face that a lot with my patients. So the way that I go about it is I say to the patients and the family, I say, if the patient gives me consent, that I can just relay everything to the kids or the husband or whoever it is that wants to know the reality and hide it from the patient. I tell them that I only feel comfortable doing that if the patient themselves says, yeah, you know what, just tell my kids. And quite often they're willing to say that, and I would document that. So if I have an elderly, frail, grandmother / great grandmother, and she may say, you know what, I don't know. I don't even know what's going on. Just talk to my parents and my kids. Sorry. And if I say, are you okay with me telling them everything? And she says, yes. And I'm like, okay, so I don't need to talk to you about the details. You don't want to know the details, just them. And she says, yes. Then I would feel comfortable doing that. Yeah. You try to work around families and their dynamics, but of course, when patient autonomy is always the first priority.
And one more question we have, you mentioned that you completed a Master's of Science in Epidemiology. So did you find that later on and now practicing in hindsight to be a good foundation for yourself going forward into your career?
Great question. I think that for sure. Especially in medical oncology, there's just so many clinical trials coming out all the time, and we need to decipher them, and we need to figure out, are they going to change clinical practice for us based on, are we going to change our clinical practice? Am I going to change my clinical practice based on the results of these studies? So yeah, certainly it's certainly been beneficial. I think I'm much more comfortable, and I can read papers at much more ease than somebody who would not have had that training.
Absolutely. Well, I think that's a great place to end off today's session. I do have a few last reminders just to continue off of what I mentioned at the beginning of today's session. For those who are interested in earning credit for their attendance, you must pass the quiz. That quiz is now posted in a couple of places. It's in our chat box. So the same place that you have posted your questions, you can also find the quiz there. It's also pinned at the top. Also, it's on our website under the virtual shouting page. So if you click onto our website, go under the virtual shouting page, scroll a bit down, you'll see a Monday and a Thursday quiz. Today's a Monday, so that's on the left side. You'll see Dr. Rana. The due date is going to be, I believe for this one, October 23rd. That's going to be a Sunday, 11:59 p.m. Central Standard Time. And if you have any questions about anything, feel free to contact us as always. After passing that quiz, like I said, you'll receive a certificate. That certificate will be sent to the email inbox of the address that you list on the quiz. So be sure to list one that you're comfortable with. We recommend a personal Gmail, Yahoo account rather than a school one. And just in case you don't find it in your inbox, please check your spam folder. But if you don't find it in either, feel free to contact us. For our next shouting session, we're going to be joined by, I believe, Dr. Khan, actually, later this week. She's in dentistry, and we'll be joined by her at 7 p.m. Central as usual on Thursday, this Thursday. We usually go around the Monday and Thursday schedule, so you'll be able to stay tuned that way. Generally, those are our 2 days, and our times are usually 7 p.m. Central, although that does vary. So if there are any changes, we would be sure to include that on flyers. Dr. Rana has her Instagram here, so feel free to shoot her any messages or give her a follow on Instagram to stay in tune with her if you'd like to hear more from her. And also, if you'd like to hear more from us, feel free to also follow us on Instagram. Our socials and our contacts, our website is all in the description on this video here. So if you scroll a bit down, you'll find our description. You can find all of our details, as well as Dr. Rana's details for her Instagram, etc., on that description. Those are all the reminders. Again, if you have any questions for us, feel free to let us know and send us an email. But it's been such a great opportunity to learn more about oncology as a specialty. We were honored to hear from you, Dr. Rana. So yeah, thank you so much again, and I hope everyone has a great rest of your night.